Good morning, everyone. This is Larry Crowder with Cervey. I'm the Vice President of 340B Solutions. And today we have a special treat. We're going to go over the ins and outs of the 340B Referral Prescription Program. And we have some guest presenters. So we have Tom Willoughby, owner and operator of 340B Max, and Bryan Murray, partner at Dinsmore and Scholl LLC. And they're going to walk us through the history, function, and best practices of 340B referral prescriptions to apply to your 340B program. So just to give a little background on each of these, I got to meet both of them at the last conference and had some really good conversations with them. And I know referrals is one of those areas there's been some more interest, especially with the restrictions going on. And so just to give you background on each of them, Bryan Murray is a partner at Dinsmore and Scholl. He focuses his practice on healthcare, life sciences, and general corporate matters, and regularly advises a wide variety of healthcare businesses, including retail and specialty pharmacies, health systems, hospitals, medical practices, residential health providers, and drug, medical device, and dietary supplement manufacturers. So he has quite a plethora of people that he advises. And Tom Willoughby is the owner of 340B Max. They're a 340B consulting firm that specializes in improving the profitability of 340B programs. And so with that, I'm going to turn it over to Bryan to begin the presentation. At the end, we will have a question and answer that you'll be able to chat questions to us, and they've been gracious enough to stay after and answer those. So with that, I'll turn it over to Bryan.
Great. Thank you, Larry. I really appreciate it. And just wanted to say thank you to Cervey and your team and the team over at 340B Max for putting on this event today. And to everyone in attendance, thank you for all taking time out of your busy schedules to meet with us today. And I hope that you get a lot of value out of this presentation today. So with that, our presentation, we are going to cover quite a few items here. So generally, we are going to be focusing on referral prescription capture, and we're going to be talking about that concept from a legal, compliance, financial, and operational consideration standpoint. With the idea or the goal of the presentation being that you'll walk away with information to understand how referral prescription capture works in effort to help grow your program, and really as a means to offset some of the financial impact that you all may have realized as a result of ongoing manufacturer restrictions. So this first slide, I always like to start 340B related presentations with this slide so we can really get a good overview of really what the 340B economy looks like. What you'll note from this slide is 340B is complex. It's a big program, despite what you may hear others say about it. There's a lot of money changing hands, inventory changing hands, and data and services seemingly changing between all different stakeholders in the program. To that end, the program has a number of different stakeholders, a population that has considerably grown since the program started in 1992. And each of these stakeholders have unique contractual relationships or other interrelationships among them, where certain process changes or certain activities that a particular stakeholder engages in may cause ramifications for other stakeholders in the program, most notably of late or the manufacturer restrictions. But there are a number of different actions that any stakeholder can take that really will have an effect in the 340B space. So really the point of looking at this slide is to really identify that there is opportunity in the complexity of the 340B program. And specific to today's presentation, one of those opportunities is referral prescription capture. So with that, our presentation, we really are going to be focusing on what covered entities can do to adopt referral prescription capture programs or implement greater use of those types of programs, as well as how that may affect patients and ancillary providers. If you don't mind, can you please turn to the next slide? So in order to understand the legality first of referral prescription capture, we really need to focus first on who is eligible to receive a 340B drug. And so on the legal end, we typically start with the statute. And the 340B statute is very unique in that it only addresses that a covered entity cannot transfer a 340B purchase drug to a non-patient. And importantly, that statute does not define the term patient. And interestingly, from 1992 up until 1996, the program operated without a defined term patient. Rather, everything evolved around what was set forth in the statute. Now, in 1996, HRSA promulgated informal guidance that really defined what the current patient definition is, and the program has since operated on this definition. However, as a side note, there is a current lawsuit going on with an entity called Genesis Healthcare, which specifically is litigating this particular interplay between the statutory term patient and HRSA's 1996 definition of patient. And the point of bringing that lawsuit into the fray here is that depending upon the outcome of that lawsuit, there may actually be an expanded referral prescription capture opportunity for covered entities. So for purposes of our presentation and really discussing referral prescription compliance, we will focus on the 1996 definition promulgated by HRSA because that's what the program is currently structured on. And so looking at this definition, in order to establish that a patient is eligible to receive a 340B drug, we first must show that the covered entity has a provider relationship with the patient and maintains healthcare records of the patient. And this can be as simple as the patient being identified as a patient in an EMR, in a medical record, just documenting that there is a provider-patient relationship. Secondly, the patient must receive a healthcare service from a provider that's either employed by the covered entity, under contract with the covered entity, or under other arrangements. And this other arrangements category is really where 340B referral prescription capture fits into the definition itself. And we'll get into that component a little more here, but essentially where covered entities are able to establish responsibility of care for patients that are referred to third parties under these other arrangements, there is a referral capture opportunity. Third, a covered entity needs to document that it maintains responsibility for the patient's care. And this is another component for today's presentation that we'll focus on quite a bit from a compliance perspective. And then lastly, with respect to federal grantees, so these are essentially all the non-hospital providers in the 340B program. The healthcare services provided and the drugs that are ultimately going to be purchased under 340B need to fit within the particular scope of the entity's grant. And it's very important to realize that certain grants can be read much more broadly than other grants. So some covered entities, depending on the wording of their grant, may have access to prescriptions in a number of different therapeutic categories, as opposed to more limited grants where you may have one or two therapeutic categories that the entity could truly consider as 340B eligible. Next slide, please. So now understanding a little bit of the legal background, we're going to turn our focus to compliance so we can understand more how referral prescription eligibility is established and how that can be documented by a covered entity. And typically when we see referral prescriptions out in the wild, they result from a covered entity treating a patient and then referring the patient to a specialist for a specific type of medical care that the covered entity itself doesn't provide. From that referral, the specialist will then provide care to the patient and write a prescription depending on whether or not it's medically necessary. And then where that prescription gets filled at a covered entity's in-house pharmacy or a contracted pharmacy, there's a potential to have 340B revenue result from that prescription. So ultimately the question here is, how do we establish eligibility for these referred patients and any prescriptions resulting from the referral? And one of the key takeaways from here is the need to document consistently, document in detail, and make that part of your pattern and practice where a referral prescription program's adopted. So with respect to the covered entity provider-patient relationship, this is a relatively straightforward in that the covered entity needs to document, typically in the medical record, that the patient is a patient of the covered entity. Secondly, the covered entity would then refer the patient to a provider for services, and this is that referral out to the specialist or another provider. And that referral itself also needs to be documented in the medical record in order to establish referral prescription eligibility. What we also counsel clients on doing is potentially documenting reasons for the referral as well. So really documenting why the referral took place and how that relates to the covered entity's overall delivery of care to the patient. Third, from a compliance perspective, the covered entity needs to maintain health records of the patient. And what this will look like is not only documenting that initial referral, but also either creating an infrastructure or receiving medical records from the specialist that's delivering care, any prescriptions that are written by the specialist, and then information showing that the care delivered by the specialist was delivered pursuant to that referral. In this particular prong of the compliance analysis, this is an area where third-party referral capture vendors, TPAs, and others can assist covered entities in establishing this infrastructure. And it's very important that that be established not only in a cost-effective manner, but ultimately in a compliant manner where we're able to fully document the referral, the receipt of care, and prescriptions resulting from that. As a fourth compliance component, the covered entity needs to retain responsibility for the patient's care. And we typically document this in a couple of different places. So first is in the covered entity's 340B policies and procedures. We typically document that referral prescriptions or a referral prescription program will be implemented by the covered entity, and that policy and procedure will really set the parameters or procedures as to how that's going to function. So identifying specific instances when referrals may happen, if there's commonly referred to providers, identifying how that process will work. Secondarily, what we recommend as well is that clients enter into what's called a memorandum of understanding with the recipient provider of the referral. And a memorandum of understanding at its core, it's really a non-legally binding contract that basically within the document, we define who's responsible for the particular care and really outline the process for eligibility for a 340B referral prescription. Memorandums of understanding are a very good piece of information to document that responsibility for the patient's care is staying with the covered entity. And so again, as a key takeaway, that's something that I would encourage anyone implementing a referral capture program to focus heavily on as a means to better establish that responsibility of care remains with the covered entity. And then lastly, tying this all into the patient definition for grantees, again, the referral recipient services also need to be within the scope of the covered entity's grant. And really this is the prescriptions that are coming out of that service. Again, grants can be written broadly, and so it's imperative that a covered entity understand what the parameters of its grant are. And typically we advise that you engage counsel to give you a good overview of what's potentially eligible under the grant and really establish a strong framework to aid a covered entity in the event that there's a HRSA audit or any other sort of questions related to a referral prescription program. Lastly, in the marketplace, there are certain covered entities that may be tempted to go and rewrite prescriptions that are issued by a specialist. We generally do not encourage that this practice occur for a number of reasons. Most importantly, there's potential professional liability associated with rewriting prescriptions, as well as you may have issues with respect to scope of practice. So your provider may not necessarily have licensure to write a particular prescription, or it may be falling outside of the scope of their practice, which could create some civil licensure or regulatory related issues. If you don't mind flipping to the next slide, please. So now knowing really the basics of the compliance and legal piece, what I'd like to turn to is really policy considerations. And what we mean by this is, what is HRSA's opinion with respect to referral prescriptions, and how can we assess really regulatory risk around referral prescriptions moving forward? So when the 340B program was initiated, referral prescriptions really weren't used in any shape or form, at least until the last few years. And that really kind of begins around the mid-2010s when we see referral prescriptions start to pop up, and they've become more readily adopted only in, I'd say, probably the last 5 years. In addition to that kind of historical shift into a referral prescription program, HRSA's guidance on referral prescriptions has also changed over time. So again, from program inception up to about mid-2010s, there really wasn't much talk around referral prescriptions until HRSA issued a policy statement indicating that where a covered entity can document that it retains responsibility for care provided by a referral recipient, that the patient could potentially be eligible to receive 340B prescriptions from that care. Very quickly after that initial policy statement was released, HRSA then issued what is notoriously known as the Omnibus Guidance from 2015. And within that guidance, HRSA specifically stated that if a patient's referred to care at an outside entity, the prescriptions resulting from that care would only be eligible if the covered entity could have billed for services on behalf of that referred to provider. And what this did is really raised a number of issues around purchase services, which in turn raised a few regulatory issues, and ultimately really was HRSA coming out and saying that referral prescriptions likely are not permitted under the 340B program except in very limited circumstances. So that sent a little bit of a shockwave into the referral prescription program. However, that omnibus guidance was later revoked. And so what we're left with now from a program structure standpoint specific to referral prescriptions is this 2014 policy statement where HRSA indicated that to the extent a covered entity can document that it retains responsibility for referral provider services, that a patient may be eligible for 340B drugs. And in addition to that policy statement, there are FAQs available through Apexis, which have been reviewed and approved by HRSA as late as 2020, which also indicate HRSA's acceptance of referral prescription programs under this 2014 or these policy statements and parameters issued in 2014. So ultimately, we don't anticipate any substantial regulatory risk to referral prescription programs from HRSA's end, and they are generally seen and held currently in good favor by HRSA. If you can move to the next slide, please. Now, before turning the presentation over to my co-presenter, I do want to talk about at least one forward-looking opportunity for covered entities, and this specifically relates to the use of telemedicine within a referral prescription program. So since COVID-19 occurred, we've obviously seen a tremendous effect on the site of care and kind of how care is delivered, with a number of patients and providers moving on to telemedicine and telehealth platforms. And as a result of COVID-19, we saw HRSA come out and identify telehealth technology as a critical technology and encouraging providers to adopt telemedicine specific policies and procedures related to 340B in their 340B policies and procedures document. Ultimately, what HRSA's guidance has been interpreted as is that prescriptions that are written through telehealth are eligible for 340B discounts so long as the patient fits within the patient definition. So referral prescriptions really represent an opportunity to preserve 340B revenue or increase 340B revenue while also increasing patient access to care using telemedicine encounters and services. So to that end, a few best practices related to referral programming in the context of telemedicine is that telemedicine visits should also be recorded in the medical record maintained by the covered entity. So not just held within the telemedicine vendor's system or the platform, but also taken out and moved into the patient's medical record maintained by the entity. Second, documentation related to telemedicine visits should be maintained in accordance with current retention requirements, and then also in accordance with telemedicine related requirements. And these can vary from state to state, and are something that we actively encourage covered entities to take a long, detailed look at, just so we're ensuring that medical records are being appropriately maintained and retained for the amount of time necessary. Third, we'd also recommend that covered entities monitor state law for changes in the use of telemedicine technologies. For example, you may have a provider located near a state border that's going to treat out-of-state patients periodically. And in that same vein, you could see where you have a referral to an out-of-state provider for treatment of an in-state patient. On that end, it's very important that telemedicine related laws and scope of practice laws are reviewed in depth to ensure that those types of referral patterns and that type of treatment is permitted under the applicable state law. And then lastly is maintaining referral documentation, very much in the same vein that we talked about kind of in the compliance program here, is making sure we're documenting that referral, documenting the reasons for it, getting access to medical records generated by the referral recipient, and ultimately any prescriptions resulting from that referral. So with that, a couple of key takeaways from the legal and compliance end is that referral prescription programs are acceptable and they are legal under the 340B program, provided that documentation is retained and we adhere to the 340B program patient definition. Second, in order to leverage a referral prescription capture program, covered entities should take a hard look at their policies and procedures and adopt not only referral prescription related terms, but also telemedicine related terms to the extent telemedicine capabilities may be used by the covered entity. And ultimately setting up a framework to maintain compliance with the program and to identify and obtain documentation related to referrals. Again, that is something that a TPA or a third party can come in and help your organization with, and is definitely, when you're considering implementing a referral program, it's very important to have those conversations with your TPAs, with your third party vendors, to make sure everybody's on the same page as to how that referral prescription related framework and infrastructure will operate. Third, we absolutely encourage covered entities to enter into MOUs, so these memorandums of understanding with commonly referred to providers, with the goal being to establish that responsibility of care between the providers, establishing that with the covered entity. And then lastly, monitoring the 340B program and any changes to applicable law. That would include monitoring the lawsuit we referenced earlier, as well as applicable state laws, and as well as laws related to the practice of telemedicine or scope of practice for your particular providers. Now, with that, I will turn the presentation over to my co-presenter, Tom, and thank you all for your time.
All right, thanks, Brian. I'm Tom Willoughby with 340B Max LLC, and I'm going to talk about the operational and financial aspects of these referral prescriptions. So we're going to take a lot of the stuff that Brian talked about as far as compliance and legalities, and we're going to talk about how the rubber hits the road here and how we operationalize this and what it can do for your organization financially. The first thing you need to understand about these referral prescriptions are they can be highly profitable to your organization. They are designed for anybody who refers services out of your facility to a specialist somewhere else. So they are especially beneficial to smaller facilities. Even major medical centers can benefit from them if they refer any services out. So think about what services your organization is referring out to specialists, and that's probably going to be a lot of where your 340B referral prescriptions come from. I've literally seen clients double their profitability by capturing these. So if your program right now is suffering financially because of the manufacturer restrictions, and you're saying, how can I replace that revenue, or how can I get my program back up to where it was financially? If you're not capturing the referral prescriptions, you really need to look at this as a way of enhancing the revenue and profitability. Let's talk about the basics of referral prescriptions, and let's kind of take some of the things Brian said and reduce it down to a more nuts and bolts approach and talk about kind of, as I said, where the rubber hits the road. So here's the scenario. A patient comes in and is seen by one of your providers, usually a primary care provider, but it doesn't have to be. Your provider then says this patient needs to see someone for a service that we don't provide. So they need to see an endocrinologist or a dermatologist or an whatever specialist it is that your organization doesn't provide that service. So they refer them out to see that specialist. They go and see the specialist, have a visit with them. The specialist then prescribes a drug for them, and they get that drug filled at one of your contract pharmacies. So maybe they have to travel to a different city or town to see the specialist, but then they come back home to one of your contract pharmacies and get the prescription filled. Or maybe the specialist is in the same town, which makes it easier for them to get the prescription filled at a contract pharmacy. But what you should be thinking about as I'm talking about this is normal course of business. You should be thinking that this happens every day, multiple times a day, especially, like I said, if you're a smaller facility. So this should be triggering in your mind that this is a big opportunity because it's something that happens on such a frequent basis. because you're doing this every day for whatever services you don't provide. So let's talk about then some of the requirements here. First thing is the prescription must pass all of the normal 340B requirements. So if you carve out Medicaid, Medicaid's got to be carved out. If your contract is brand only, it's got all the generics are excluded. If you exclude C2s, then they're not eligible. The prescription itself has got to meet all of the criteria that any normal 340B prescription would meet before it's eligible. Next is you have to have the referral to the specialist in your medical record system. So you have to prove that this patient was seeing this specialist because you sent them there, not because somebody else sent them there or they somehow got in without a referral. You have to prove that you sent them there by having the referral in your medical record system. Then you need to have notes back from the specialist as documentation that the patient actually kept their appointment, had an encounter with the specialist. Now, it would be an extremely rare scenario for a patient to actually get a prescription from a specialist without actually seeing them, but the requirement is you have to have the notes back showing that they did keep their appointment, they did have an encounter, and then the patient has to get the prescription filled at a pharmacy that you're contracted with. It can be, if you have an in-house pharmacy, it can be your in-house pharmacy. It can be any of the pharmacies that you are contracted with, whether you're contracted with them as a local pharmacy or whether they're some kind of specialty or mail order pharmacy. As long as you are contracted with them, that meets the criteria. So let's talk about some of the TPA considerations. So, and let's understand what role the TPAs play in this. Most TPAs, but not all, will charge some additional fee for the referral prescriptions. Some actually outsource the whole thing to a third-party vendor, and that third-party vendor is actually going to do all the work for you, basically, or at least a huge chunk of the work, okay? Now, the fees for capturing these prescriptions can vary widely. Some TPAs charge no or minimal fees. Others, especially the ones that outsource it, charge a much larger fee, usually a percentage of the amount you're going to receive. So if you're evaluating TPAs and comparing one to another and deciding which direction to go, if you're going to capture referral prescriptions, understanding what the fees are from that TPA is significant because it may sway you one direction or another depending on what TPA you're going to pick. And let's talk about operationally how this works with the TPAs, okay? What generally happens is the TPA has a separate section of the portal where you can see all the prescriptions that are eligible for a referral prescription. And when I say eligible, they mean they have pre-screened it to say, okay, this meets all the other criteria, and this looks like it is somebody that is your patient because we've seen that this person has an encounter with your physician. So it looks like it's your patient, but the prescription was not written by your physician, it was written by a specialist. What you will need to do, and this is very simple, and one of the things that people get hung up on is they think this is a much more complicated process than it is. You typically have to go in and just check a couple of boxes, basically verifying and saying, yes, I have the referral, and yes, I have the notes back from the specialist. You don't typically have to scan those documents into and upload them to the TPA portal. You just have to click boxes saying, yes, I've got those. Now, there's always a section in there for some kind of notes or comments, and I highly advise putting some comment, something written in the notes or comments section that if you are audited, you are able to produce these things. So whether you need to put the medical record number in there, whether you need to put some other identifying information, or exactly where within the medical records the referral and the notes are stored, but make sure you have documentation so that if you get audited, it is easy for you to produce the referral and the notes. But typically you click those buttons and you've represented now that you have that information. Now the TPA is going to process that referral prescription. It's that simple. It's not a huge time-consuming effort. It's not extremely difficult, and it's actually something that generates a lot of revenue for the organization. But let's wrap this up kind of by talking about the differences between the referral and the non-referral prescriptions. the referral prescriptions are not processed as a TPA as part of their normal suite of services. So if you're sitting here going, I'm not sure if I'm capturing referral prescriptions or not, the answer is you're not, because they are just not processed as part of a normal suite of services. The non-referrals are. The referrals only get processed if you go in and click the boxes in the separate section of the portal that says, yes, I have this information. The referral prescriptions, and I'm on the second box now, require additional documentation and puts additional compliance responsibility on you as the covered entity. Now, in non-referral prescriptions, you are still responsible for the 340B compliance, but the TPA does a lot of the compliance work for you. When you are clicking those boxes and saying you have the referral and you have the notes back from the specialist, you're taking that compliance responsibility on yourself. The TPA has nothing to do with it. So that is 100% on you. So it's important to make sure you have somebody doing this who understands the medical records, understands what they're looking at, knows how to document it so you'll be able to retrieve it if you're ever audited. But it does put a little bit of additional compliance responsibility on you. Next bullet point is the CE is responsible for documenting they have referred the patient to the specialist and the patient had an encounter. That's additional documentation that you have that you don't have to have with a referral prescription, that the TPA will just process the non-referral prescription without any additional documentation. And lastly, the TPAs typically don't adjudicate the referral prescriptions until the CE has confirmed that above documentation is in place. So you can go in and look at that section of the portal, but until you actively say, yes, we have this stuff in place, it's just going to sit there as like a pending claim and is never going to be processed. So you have to actually take some action to get the prescriptions processed, whereas the non-referral prescriptions, they are just automatically adjudicated by the TPA without any additional documentation or any approval from you. So there's some differences between referral and non-referral prescriptions, and that is kind of where we are going to wrap this up. There is contact information for myself, Bryan, and Larry, and I am going to turn this presentation back over to Larry.
All right, thanks, Tom, and thanks, Bryan. That's very nice presentation, really good information about referrals. For those of you on the call that are Cervey accounts, I do want to mention we do have a referral reconciliation model that pretty much mirrors exactly what Tom just relayed that TPAs will have. There is no additional charge for that, so if you want that set up, all you have to do is contact us and we will get with you to set up that referral reconciliation module and go through the specifics of how that's set up. So with that, I'm going to open it up for questions. And I see one's come through already, but just for those of you who don't know, there is a little panel there that says questions on it. So if you have a question that you would ask, that you would like to ask Bryan or Tom, all you got to do is type it in and we will see it, and I will relay that to Tom and Bryan. They've been gracious enough to stay after to answer some. So here's the first question to Bryan or Tom. Is there a database that tracks 340B funds received by eligible hospitals? I'm not sure of any database where they track 340B funds received by eligible hospitals. So I guess one of the questions would be, if when you're saying funds are, because basically they're buying the drug at 340B price. So are you asking, like, with whatever they get as far as 340B revenue, is anybody tracking that? And that is I know each individual hospital has their own tracking of what they're doing with that revenue. Is there anything, Tom or Bryan, that spark any thoughts on that question?
There's nothing that I know of that tracks individual hospitals, like a national database. There's nothing that I know of that tracks that, unless Bryan knows of something.
No, and I'd jump in on this and say there's no known third-party database, so something that you'd see like through HRSA or a regulator or another entity that tracks specifically what the 340B savings resulting from a dispensation would be. Covered entities absolutely internally should, and I think do track this information, but there is, to my knowledge, no third-party database where that information would be stored.
I think it's good to mention here that it's a great question. I think if you're a covered entity, one of the things that I would encourage is that you look at ways that you're expanding your services or you're passing those savings down to patients that need it most. And you definitely want to track that, if not even for your own tracking, but just for political purposes of the program. It's really good insight for everyone to see what the program's doing for those who need it most. So I have another question here. It says, and I don't know if I can see the whole question. Maybe I'll make it wider. Oh yeah. Oh, nope. It's not letting me see the whole question, but it says, Bryan, the MOU for specialists, what does this need to include or cover?
Sure, yeah. So with respect to the MOU, again, it's a non-binding legal document. So we don't want to look at it like a contract that's going to impose obligations on the parties thereto. Basically what the MOU is, it's an understanding between two entities, and this is the covered entity and the recipient of the referral, that's going to establish who's responsible for the care. And so typically what we'd see in an MOU is identifying who the parties are, identifying the routes through which a referral could occur. And these are all typically going to be similar across most MOUs, other than the parties' names. And then establishing that where we have a referral from the covered entity to that particular provider, that the covered entity is retaining responsibility for the care that's related to the referral. And then what we'd like to call out as well is that the covered entity is going to essentially claim some of these prescriptions as 340B eligible to the extent they meet program requirements, and then affirmatively advising the recipient of the referral that they are to not claim these as 340B discounts. So you could see a scenario where a referral may happen between one covered entity to another 340B eligible covered entity. And what we want to do is make sure that we head off any instances where both entities may claim a discount on the same prescription. And so ideally what the MOU does is establish that relationship between the entities and identify who's going to retain responsibility for that patient's care.
And Bryan, you may have answered that within that, but I just wanted, I was able to open up the second part of the question. And so the second part says, if the specialist's practice is outside the scope of the CE, so an example would be neurology, would those scripts qualify?
So, and this is a really good question. On the hospital end, let's say you're a disproportionate share hospital, typically no, this is not going to be an issue. Most prescriptions that are going to be written are going to fit within the hospital parameters. For federal grantees, yes, this could become an issue depending upon what prescription's written. So you could see, for example, if I'm an STD grantee and I refer a patient out for neurology to a third party and the care delivered is completely unrelated to sexually transmitted disease care or really ancillary care to that type of service, that would be a situation where you'd want to look very closely at your grant and figure out, is care that's ancillary to an STD related service going to fall within the scope of my grant or not? If not, then I would say that particular prescription, we would not want to flag that as a referral capture eligible prescription. But to the extent that your grant is written broadly and you can make an argument that these ancillary services are covered, you could, in theory and hopefully in practice under your grant, claim that as 340B eligible.
Okay. Bryan, let me throw something else out here and make sure we clarify this. When you're talking about the MOUs, having that in place is recommended or maybe a best practice, but it's not an absolute requirement. Is that correct?
That's correct. It's not an absolute requirement, but what we'd like to have those in place for is that in the event a prescription is audited and they say, well, how did you establish that care remained with the covered entity? We can then pull the MOU up and say, both parties to this particular incident of care have essentially discussed this issue and determined that the covered entity is going to retain responsibility. So the MOU, it's somewhat of a belt and suspenders approach to compliance, but because it's relatively easy to get those documents prepared and put into place, it's something that we actively recommend clients engage in with respect to referral prescription programming. And
so, Bryan, we have some more questions around this. So this is a popular topic in in the presentation. And the next question is, what is the best way to identify referrals in the EMR so you know who to reach out for an MOU? And does someone have a sample MOU?
Sorry, Tom, go
Bryan
ahead.
may have a different answer. Bryan may have a different answer on this, but typically the TPA will give you a whole list and say, these are the prescriptions that are potentially eligible, because they're going to go through and say, oh, it meets all the 340B criteria. It looks like it's your patient because we've had an encounter at your facility with one of your physicians, but this particular prescription is not from one of your providers. So typically I would think that the TPA, just by giving the list of here's the potentially eligible 340B referral prescriptions, you can look at those and say, oh, these providers are with this practice or this facility. That's probably your best way to identify who you need to get an MOU with.
So I know that we just had a conversation with a current customer of ours, and so that is true that we can, as a TPA, show you all the scripts that essentially had an encounter. It's one of your patients, but the prescriber is not on your list. I know that some of the EMR systems keep electronic data around referrals, so getting a list of those referral physicians, we've had that to where when we set up the referral reconciliation module, a lot of times we will get a list of commonly referred to physicians from the covered entity themselves, because they can grab that information from the EMR system they have some sort of electronic documentation around referrals, and they just grab a list of the physicians that those have been sent to. So I know that has happened in the past. I don't know if you had anything else to add to that, Bryan. Is that
No, I think you both covered that very well. The only thing I really would add is we absolutely do have template referral letters of understanding, memorandums of understanding that can be used in this juncture. And so if anybody has questions regarding those, absolutely feel free to reach out and we can kind of talk through what those look like and reiterate kind of the components that you'd want to include in those in an MOU.
And we have a couple more questions here if you guys have a few minutes to hang. So I'm going to read you this, and there's an example that they give, but the question is, it is required that you have the referral out in order to be compliant with referrals. That's a question. And the example they gave is you can't have clinical note expressing your physician as primary physician and specialist as part of a patient healthcare team, have notes and prescriptions from specialist visits, but no referral out. So I guess they're asking, is that referral out piece absolutely required, or is it okay if you just have a clinical note expressing your physician as primary physician and specialist as part of a patient healthcare team?
Mm-hmm. So I would say from a best practices perspective, we absolutely want to have the referral out documented in order to establish that the referral originated at the covered entity. So for example, I know Tom alluded to this earlier, you could have situations where a patient arrives at a specialist's office kind of on their own volition without a referral. You could see in the clinical notes that the covered entity becomes aware of this, and we identify the specialist as part of the patient's team, but there really wasn't a true referral. That being said, this particular example, there's a little bit of an element of a business and compliance and risk-making decision that needs to be made here, in that if we're confident that there was a referral between the covered entity and the specialist identified as part of the care team, you could absolutely make a business decision to say, we're essentially going to represent that, yes, we have sufficient documentation to show that this patient was treated by this provider under other arrangements, and that we have enough information resulting from the care to show that the patient's care, the responsibility for that care, remains with the covered entity. That's probably a long way of saying this particular issue needs to be looked at independently, really on a case-by-case basis. But ultimately, we would encourage that referral out piece be documented as a way to kind of head off this case-by-case analysis and to add a little bit more compliance to the referral capture program.
Okay.
I would add to that, from a matter of practicality, if you haven't got a referral in place, do a referral now. On the patient's next visit, do a formal referral so that you have it going forward. You know, just because you haven't done one to this point, I don't think there's anything that prevents you from doing one now so that you have it in place going forward. Another thing that while we're talking about the referrals, that I want to say is there's not a timeline on a referral. So if I came into your facility and got referred out to a specialist 5 years ago, and I'm still seeing that same specialist, that referral from 5 years ago is still good as long as you have it in your system. But in the particular case you're referencing, I would say do a referral now, as long as you meet all the medical criteria and appropriate, so that you have that issue addressed going forward.
Great. So we have one more question here, and then we'll close out the webinar for the sake of time for everyone. But the last question I have is, so if the specialist scope is outside the CE, how can the CE still retain responsibility for the care that is in the scope of the specialist? And they go on to say, and if the specialist would otherwise be able to claim 340B discounts, what incentive do they have to enter the MOU?
Mm-hmm.
From a matter of practicality, and this is, I'm just saying, this is how I see it working a lot of times. The specialist may not be 2 blocks down the road. The specialist may be in a different city, okay? Maybe they're 20 miles away or 50 miles away or however far away they are. In that scenario, the specialist is not going to have, or is highly unlikely to have, your local Walgreens or Walmart or CVS or whoever they're getting their prescription out of, they're unlikely to have that pharmacy under contract, so they wouldn't be able to claim it anyway. A lot of times, they're going to have maybe the pharmacies geographically close to them under contract, but the ones in your city or town they may not have. So they are not giving up anything if there's a geographic distance and they don't have that pharmacy contracted anyway. That's what I run into a lot. But again, I work more in rural areas and smaller clients. Bryan, you may have something to add to that, but from that perspective, they're not giving up anything. So they have no reason to not sign an MOU.
Yeah, I think that the one thing I'd add, and I won't address the incentive to enter into the MOU, but with respect to the specialist scope, typically the scope of care the specialist is going to provide is going to be outside of the scope of care that your facility delivers. But that does not necessarily mean that prescriptions resulting from that care fall outside of really the scope or intent of the grant. So for example, you may have an infectious disease clinic that's eligible for 340B, and we have a patient where they're receiving hepatitis related services, for example, and we need a referral out to a gastroenterologist or a hepatologist that's not on staff at the covered entity. That could be a situation where that referral to that provider, the care that they're delivering, it's very much related to the care that's being provided to the patient at the clinic. And I think that would be a good example where you could see the provider's scope of services at the referral recipient at the specialist is definitely outside of the scope of what's provided at the covered entity, but the care falls within the scope of the purpose of the grant. And so I think the point being that if you are going to implement a referral prescription program or add some more parameters to your program, it's very important to understand what your grant language looks like and what's permitted in terms of kind of coverage under the grant from a 340B perspective.
Perfect. Well, we're going to wrap it up. I do want to mention a couple things to everyone who's still on. It's been a very attentive audience, and most are still here. So I could tell this was a subject that people were interested in hearing in. Some of the upcoming webinars that we're going to talk about, I already have scheduled in my head so it's not scheduled out to you yet, but it's going to be coming, is a webinar on the cash card. So there's a lot of things that you can do with a cash card program that you can really manage that benefit so that you don't have to worry about it getting out of control, and you can put some caps on it and things like that. And so for those of you who might still be interested in passing some savings on to those who need it most, an opportunity to help those in your community that need it most, that is a viable option. So that we're going to be upcoming a webinar on cash cards and all the things that you need to know about cash cards. But this was really our first time to do an outside vendor to come in and do a webinar. And Tom and Bryan, you did a tremendous job on this. I would love to get feedback from anyone out there on what you thought. If there's a topic that you want to hear, we're definitely looking at continuing to do this to just bring some education to 340B and to help our client base and really anyone. We'd like to invite anyone. Lastly, I do want to say we're going to send out the slide deck to everyone. So don't worry, you will be getting the notes. These questions will be part of the email with the answers in there. And then, you know, I'm not sure, we did record this. So if you need a recording of this, I'm not sure if we automatically send that out, but certainly feel free to request it if you want to see a recording of this for later. So with that, I will end it. Thank you so much, Tom and Bryan, for coming and presenting. Excellent job. And I hope everyone has a really good day.
Thanks a lot, everybody.
Thanks, everybody.